Lausanne. So it's my privilege to announce for the second talk, Sandu Kishore from Lausanne. He is the head of pediatric ENT surgery there and has an incredible experience with advanced tracheal, bronchial, and also esophageal problems. And I'm particularly happy that Sandu is covering the tracheoesophageal fistula aspects in pediatric patients.
The outstart, thank you very much for a kind invitation, Walter. And it's a pleasure to be here. First time for a thoracic surgery conference. We have been in this center, convention center, for the European Society of Pediatric Otolaryngology. Fantastic place. Thank you so very much for a fantastic meeting. So as, in fact, the title actually suggests, I'm going to zip you through what happens in the pediatric age group, which is quite different than adults. We do adult as well as pediatric work, but pediatrics, I can tell you, is a nightmare. No conflict of interest, and I am going to sort of take you through a couple of routine kind of topics in children. So this is actually based on a recent article that we have sent for consideration, and it is basically based on the point of criticality in tailoring down the treatment of these fistulas in children, and this is critical. Remember that, as Conrad said, that there are certain causes which are similar and overlapping in children, but in children you have congenital background associated problems. You have the associated laryngotracheal lesions, which makes it extremely tricky. And remember, is the fistula demography in small airways, which is going to make it even more complex. Symptomatology, everyone knows, but the point I'm trying to make is what is written in red here. These children are coming to you with very severe respiratory symptoms. They have dying spells, they have early tracheostomies, and they have a whole lot of comorbidities which can make your overall treatment very, very difficult and long. Have a look at this child. So this is a child who is 6 months of age, and he has got at least 8 times dying spells at home. This is a video which was recorded by his parents, and he is quite distressed. And this is his endoscopic picture showing a very severe kind of tracheomalacia and a floppy airway, which makes it even more difficult in treating these patients with a fistula. Second child is a child with mental retardation, tracheostomy. She is on non-invasive ventilation, oxygen 24/24, exclusive PEG feeds, multiple hospitalizations, and we will tackle these 2 cases a little later. So you have a congenital problem, which adds on to all the acquired problems, and we will start off by tackling the congenital background problems. So let's start with esophageal atresia and the TOFs. Prevalence is rare. You have associated malformations, and this is again straight from the books, but this will actually give you an idea what we will actually take you to in these kind of children. So majority of the times you have type 3 fistulas in the esophageal atresia. So this is the most common one. Our job is quite easy. We go in there, we put in a urinary catheter, and then the pediatric surgeon or us takes over, and we can actually feel the fistula whilst we have been closing it. So this is an easy step, straightforward thing. Now, things go a little difficult when you get more and more towards the rarity. So this is an H-shaped fistula, 16-day-old girl, 1.4 kilograms weight, 32 weeks premature, severe respiratory distress, and what we couldn't do from the tracheal side, we actually now have to do from the esophageal side, and that gets a little tricky in very, very small esophagi. And then the surgery is pretty simple. Go ahead, do a cervicotomy, identify the trachea, identify the esophagus, identify the fistulous tract, and then actually go ahead and do the surgery. Now, the second problem that we find is when you have laryngotracheal clefts which have been repaired. Again, for sharing with our thoracic surgery colleagues here, you have a variety of laryngotracheal clefts, meaning that the party wall between the trachea and the esophagus is absent. So the way we do it is basically we do it under spontaneous breathing, no tracheostomies. This is no endotracheal intubations, but the point we try to do is we just try to take the laser, we actually freshen down the edges of the cleft, and then we actually create two layers, one in the front, one in the back, so a laryngotracheal layer and a pharyngoesophageal layer, and then we actually throw some couple of sutures there, and then we actually close that. That's the easier part. Now, one of the things that happens is that why do you get tracheostomy fistulas or tracheostomy-related fistulas in these kind of patients is typically because it has not been done correctly. So one of the points that we always keep and train our residents is that if you have to do a tracheostomy in a cleft patient, try to keep it as low as possible so that you do not have any trauma or frictional trauma that actually is going to interfere with the cleft repair. Now, things get even more rarer. So you have laryngeal atresia. This is a child who has been delivered by an exit procedure, meaning it's ex utero intrapartum, meaning fetal-maternal circulation is maintained, a tracheostomy has to be performed in the child, and then the child comes out. The problem is that they are always associated with a tracheoesophageal fistula, and this gets even more difficult when you have a tracheal agenesis. So this is a child where you have no trachea, but you have a fistula, so you are able to ventilate the child for some period of time. Unfortunately, this is one indication where even a tracheostomy is not to be done. This is a child, unfortunately, who had to die because this is a difficult condition to treat. Let's go into the etiological factors related to acquired causes. So you have the endotracheal tube or tracheostomy-induced problems, where typically you have certain predisposing factors, larger sized tubes, the tubes which are incorrectly fixed. You have the tracheostomy cannula which keeps on moving, sort of rubbing on the posterior wall of the trachea, and this is between the esophagus and the vertebral column. So that's the problem. So you have a foreign body in front, you have the wall between the esophagus and the trachea and the vertebral column behind, and that's where in fact the problem starts happening. Caustic injuries, foreign bodies, penetrating blunt traumas in children can give you a problem. So let's go very systematically and understand what are the various investigations that one needs to do. And believe me, this we do even in adults. So clinical endoscopy is something which is extremely important. Again, concentrate on things which are written in red. It's the endoscopy which actually gives you every necessary detail. Airway dynamics, fistula demographics, number, site, size, fistula tract itself. Is it a shallow tract? Is it a long tract? How many rings below the fistula? How many up to the carina? How many rings above the fistula up to the vocal cords? Associated laryngotracheal anomalies, and then of course reflux and other issues. In children, you cannot do as well in adults any kind of a barium swallow. So the one way in which we actually really confirm this is, of course, by doing a good endoscopy. But if you have a very, very small fistula, then we actually put in a small sort of catheter, a nasopharyngoesophageal catheter, push in a little bit of blue, and then actually see at the same time in the trachea if it is spilling over. So in children, as far as the treatment of the TEFs is concerned, you have a variety of options. Now, that is exactly the point I'm trying to make, that you cannot treat everything with the same surgery. And as you will see with these slides that you'll be seeing in the next couple of slides. So you have endoscopic approaches, open approaches, and the problem is that you cannot get away without treating the laryngotracheal associated conditions. So simple things are recurrent fistulas, which typically have narrow, non-patulous, small fistulas, which are best suited, but we actually give them 2 or 3 attempts, but if it is not going to heal, then we go actually ahead and do an open surgery. The way we actually do it is we use a brush, a cytology brush. Remember that you need to denude the epithelium, as Conrad made a mention of that. If you do not denude, no matter what you do, it's going to recur again. Now, typically, have a look at this. So this is a quadrification at the carina. So you have the left main bronchus, right main bronchus, the fistula, you have the pig bronchus there, and then you had a recurrent fistula which was communicating with the mediastinum. The surgeon who had actually operated the esophageal atresia had given an iatrogenic fistula in addition to already recurrent fistula. So this was an easy case where we went ahead, we did a scarification, we put in a couple of sealant materials in the fistula, and it healed well. What is important is that you do not want to increase the collateral damage in a small child, because remember, the airway is extremely small in these kids. So the same cytological brush that we are using in the same fistula to denude the epithelium, and then you can put a couple of sutures in that, but again, no tracheostomy in a child. It is easy to get into the tracheostomy and put the sutures, but when you do not have a tracheostomy, you need to start fighting for the airway. This is a child who was actually having a recurrent fistula after a laryngotracheal cleft repair. And what happens in these patients is that there is a downsinking of the proximal cleft repair. So in addition to closure of what is down, you need to close what is up as well. If not, the child will bronchoaspirate. This is an interesting case that we saw of that girl child who was mentally retarded. She is 3.5-year-old syndromic child, mentally retarded, had multiple surgeries in the past. And as we said, that it was extremely stressful for the parents and the healthcare providers to take care of her. So the way we actually did that was by doing a combined approach. So we actually went ahead, used the laser. Again, we created two layers of epithelium, one in the front, one at the back, and then we actually closed that. And we closed the cleft, but apart from that, we also treated the distal tracheoesophageal fistula. So in fact, this was a concomitant fistula lower down, which was treated along with a large residual fistula in this particular child. So we actually saw this child in 2017 who was extremely complicated, and after the surgery, in fact, in 2018, if you see here, that we have a complete change of this particular child. She was tracheostomized. Of course, she will require to keep the tracheostomy. Remember, she is mentally retarded, has got multiple comorbidities, but she was on non-invasive ventilation, oxygen 24/24, complicated cannula care, complicated situation for the parents. And today, she is still with a tracheostomy, but this is a much more better to manage child. She is orally feeding and has got peg feeds in addition. Now let's move our attention to the open treatment in these patients. Remember, you have to consider two factors. One is fistula related, and the other one is the management of the airway. So when you're looking at the fistula related, all these problems start coming in as far as the open approach is concerned. So I would reserve my open approach for a large fistula, multiple fistulae at adjacent sites, shallow patulous tract. If you have a residual tracheoesophageal fistula after a laryngotracheal esophageal cleft repair, failed endoscopic treatment, corrosive TEFs, and usually we reserve that after about 4 or 6 months after the injury. And apart from that, of course, you need to look at the concomitant management of the airway. So you have almost about 4 or 5 different types of surgeries now that start coming in your platter. So the cervical approach is basically a transtracheal approach, tracheal resection anastomosis, which is the bulk of the treatment. We did an extended cricotracheal resection and a cervical slide tracheoplasty. We'll see these points a little bit later with these slides. So this is a child who came with a simple, straightforward fistula, and we actually thought that this was easily taken care of by a transtracheal approach. The child also had a localized malacia. So the child also had a localized malacia which needed to be treated. Otherwise, the child will continue to have respiratory distress. So in fact, we used external rigidification with polydiaxonone plates. We sutured the fistula endoluminally, and then we actually rigidified the external exoskeleton of the trachea. A transcervical lateral approach, a simple, straightforward thing, but there are two possibilities. Either you have a tracheostomy or you don't have a tracheostomy. If you have a tracheostomy, then eventually you have to do a circumferential dissection, identify the tract, and then actually close that, and then slide in an interpositional tissue, which could be either a muscle or periosteum, perichondrium. You can use whatever you want. I think I would like to make a mention about what exactly we do in a segmental tracheal resection and anastomosis in a child. So all the steps that Conrad spoke about is the same, but concentrate on, again, the things which have been written in red. Esophagus has been closed here. which is closed vertically. The trachea is closed horizontally. Now, one of the things that we always do is we try to keep the esophageal suture line and the tracheal suture line not juxtaposed, meaning they should not be kissing each other. The moment we are kissing each other, the moment we have the two suture lines onto each other, they have a big chance of recurrence. And then, of course, these children are extubated on table if they are a little older kid, but anyone who is less than 10 years of age, we would like to keep the endotracheal tube for a little bit period of time. An open repair is something straightforward. You have to identify the fistulous area, and then, of course, as Conrad took us through the steps very nicely, do a segmental resection and anastomosis. This is an interesting case of a child who was actually operated at 18 years of age, but he was operated at the second day of life for an esophageal atresia with a tracheoesophageal fistula. He continued eating, but with bronchoaspiration to liquids, and finally, in fact, the pulmonologist referred the case to us, wherein we saw that there was a huge fistula, of course, a straightforward tracheal resection and anastomosis, and this is the end result. We reserve slide tracheoplasty, meaning that where you cannot excise a lot of trachea, but it is reserved if you have a fistula, and in addition to that, you have an airway stenosis. So you cannot remove the trachea, but at the same time, you need to close the fistula. So the way we do it is that, I'm not sure whether you know the principle of slide tracheoplasty, but again, maybe for the younger colleagues here. So if you have the trachea here, so you actually divide the trachea at a particular site, then you have a proximal segment, a distal segment. The proximal segment you actually divide at the back, the distal segment you divide in the front, and then you actually slide the two segments onto each other. This is for the tracheal side. For the esophageal side, you will close it primarily as we have done in all other cases. So this is where we are actually excising the part of the stenosis, if it is required, a very small segment, close the fistula, and at the same time slide the trachea onto each other, so as we have two suture lines which are away from each other. You have the esophageal area which has been closed here, and then you have the oblique cervical slide tracheoplasty suture line which are not in the juxtaposition with each other. And then we had a case of a patient with a laryngeal atresia. They usually have a proximal tracheoesophageal fistula, and these patients require a extended cricotracheal resection, meaning you have to identify the fistula, close it the way we have seen it in the past, at the same time treat the laryngeal atretic part with an extended cricotracheal resection by using a rib graft in addition. Sometimes you have a situation wherein you have a tracheoesophageal fistula, but in addition you have a tracheocutaneous fistula, as you just saw there. You had a tracheoesophageal fistula, as can be seen here, and then of course these patients will require a single stage resection of the tracheocutaneous fistula in addition to the tracheoesophageal fistula. Remember, these two suture lines should be away from each other. And then just the last couple of slides of treating the floppy airway in these patients. Again, we go back to our patient who has got this kind of airway. So how did we treat his floppy airway? Let me just stop this, because the way we actually did that is by using the laser endoluminally. And we actually started scurrifying into the area of the tracheoesophageal fistula, because remember, that's the area where the trachealis muscle is absent. So we use the laser to denude the epithelium, and in fact, the entire tracheal wall was completely denuded. And the reason why we did that was basically to induce fibrosis, to induce stiffness, and to rigidify. And this was the end result, what we actually got. So this is pre-op, and that is actually post-op, 3 months, and the child did really well as far as his floppiness in the airway is concerned. Sometimes, or not sometimes, all the times now, if we have a tracheoesophageal fistula with a child who has got respiratory distress, then the way we actually do it is by doing a posterior tracheopexy, meaning that you have the fistulous opening which was there. We do a cervical approach. We identify the trachea, the fistulous tract, the esophagus. The esophagus is moved to one side, and then the posterior tracheal wall is actually fixed to the prevertebral fascia and to the anterior spinous ligament. And the reason why we do it is to prevent, in fact, a posterior to anterior tracheomalacia. And the same child, in fact, at 1 month of age, in fact, you can see that is having a much more dynamic rigidification, or you may say static, in his airway and in his floppy airway. So this is, again, going back to the criticality in tailoring down the treatment depending upon what case you have. We had the two basic problems. We had feeding problems and the respiration. So if you see preoperatively, you had patients with PEG and oral feeds who now are completely having orally. And as far as the respiration is concerned, they were having severe respiratory symptoms. Today, they are much more better off and have been decannulated as well. So just to sort of give you a brief concluding remark, remember that even the smallest of the TEFs is unlikely to heal spontaneously. It's not possible because the epithelial tract is not denuded. Endoscopy is the gold standard for the diagnosis. One needs to individualize the treatment. It could be endoscopic, it could be open, it could be combined. No matter what it is, we cannot have the same surgery to be used for all patients. The treatment depends on the etiology, the fistula demography, and the associated laryngotracheal anomalies in these very sick children. Just a small sort of information. We run a Lausanne airway course where we actually have the airway surgeon. This could be an ENT, pediatric surgeon, thoracic surgeon. This is for adults and pediatric. Intensivists, adult and pediatric. Anesthesiologists, adult and pediatric. So it's a common platform for all those guys who are involved with airway sharing, and this is what actually we do in our institution. And we welcome you to visit us in Lausanne in January 2020. I once again thank you very much, Walter, for the invitation, and thank you very much for a kind attention as well. Thank you very much.
Thank you so much. Thank you so much, Kishore. That was a fascinating talk. That was the reason I didn't cut your talk, because we were very much over time. We quickly have to ask for